All right, I'm going to give a demonstration of the lung exam. The patient is seated, gown opens posteriorly. I want to note now that anytime we auscultate or use the stethoscope during this exam, the head of the stethoscope needs to be on the skin. All right, so the first part of this exam is going to be blood pressure. We'll apply the blood pressure cuff. Again, should be over the brachial artery. See the crease of the faucet to the bottom of the cuff is approximately 1 inch. 2 fingers snugly underneath. We're going to estimate the systolic pressure through palpation, find the radial pulse, and I'm going to increase pressure until this pulse obliterates. When I no longer feel the pulse, I'm going to take my reading, and that is the estimated systolic pressure. To that pressure, I'm going to add 30 millimeters of mercury, and that's what I'm going to pump the cuff up to as I take blood pressure. So I'll pump up to the estimated systolic pressure plus 30 millimeters of mercury. When I get there, I'll release pressure slowly at about 3 millimeters of mercury per second until I get my reading, and I'll report my reading in even numbers. All right, after we've completed blood pressure, then we're going to go ahead and start with inspection. First thing I'm going to do is inspect the rate, rhythm, and the amplitude of breathing. Now, common change of rate is tachypnea. It can be caused by pleuritic chest pain. Common change in rhythm could be Shane Stokes breathing following a stroke. Common change in amplitude could be hyperpnea due to increased metabolic demand. After I've looked at the rate, rhythm, and amplitude of breathing, I'm going to walk around and I'm going to examine the bony thorax for size and symmetry. Changes I can see here are pectus excavatum, which is a congenital ingrowth of the costal cartilages. I might also see flail chest due to fractures from trauma. I'll continue to inspect the chest both anteriorly and posteriorly, looking for rashes, masses, lesions, and scars. A mass I may see is a Virchow's node. That's an enlarged left supraclavicular lymph node. That is common with metastatic GI cancer. I may also see a rash such as shingles. Shingles is a vesicular rash, usually dermatomal, caused by herpes zoster virus. Finally, I'll come around front and I'll inspect to see if there's any recruitment of the accessory muscles of inspiration, looking specifically at the SCM and scalene muscles. Commonly, they are recruited with emphysema. After I finish my inspection, I'm going to go ahead and palpate. I'll start with general palpation. I'll tell my patient, you're going to feel me pressing on your back. You let me know if any of this is painful or hypersensitive. I'll come around front. Same thing. Please shield for me. Let me know if this is painful or hypersensitive. And it should be noted that if I can recreate his symptoms, his pain, through palpation, that commonly points towards a chest wall issue. All right, next we're going to do chest expansion. I'll let my patient know you're going to feel my hands on your back. It's going to be a little pressure. You breathe in when I ask you to. We'll come to T10. Compress, deep breath in, and my hands should move with the patient's chest. They should not move separately. Now, if one side fails to initiate or there's lag on that side, that's the side of pathology. That's an abnormal finding. A common cause of that could be atelectasis unilaterally on that side. Now we'll move on to tactile firmitus. Every time you feel my hands on a new place on your back, I want you to say the word 99 in a deep voice. Shield for me. Same thing, 99 in a deep voice. Good. Finally, I'm going to check for tracheal deviation. You're going to feel a little pressure on your neck. I'm going to look at your trachea. Look away for me. Good. Look this direction. Good. Look straight ahead. And I'm going to follow the trachea down, making sure it's in the midline. If there is ipsilateral deviation, that can be caused by atelectasis. Contralateral, anything space occupying, such as a tumor or pleural effusion. All right. We'll move on to percussion. Now, with percussion, I'm going to start with general percussion. You're going to feel some tapping on your back. You just relax for me. I should hear resonance. If I hear dullness, that could be a sign of consolidation from pneumonia, hyperresonance, alveoli, distension from emphysema. come around front. Same thing, if you'll shield for me, just relax. Start at the apex. Next, you're going to feel some tapping on your back. I'm just going to check your diaphragm. When I ask you to, I'm going to have you breathe, okay? In and out and hold. Just breathe normally for now. So I'll start in resonance. Come down until I hear dullness. Should be approximately T10. Now, if you'll take a deep breath in and hold it for me. Now, I'm going to come down below that mark until I find the new level of dullness where the diaphragm has descended to. I'll mark that. Breathe normally. Now, in, out, and hold out for me. And I'll come up until I hear resonance. That will mark diaphragmatic excursion. Normal excursion is 3 to 5.5 centimeters. If you have decreased excursion on one side, lots of things can cause it. An example would be hemiparesis of the diaphragm. We'll come to the other side. Come down until we find dullness. It should be approximately T10. Breath in and hold for me. We'll go down until we find the new level of dullness where the diaphragm descended to. Mark that. In, out, hold out. And we'll come up until we find resonance. Mark that. That gives us our diaphragmatic excursion. All right. Finally, we're going to listen. I'm going to listen to your breathing, okay? I want you to go ahead and clear your throat for me. Every time you feel this stethoscope on your back, I want you to breathe in and out through your mouth. Let me know if I'm going too fast. Again, stethoscope has to be on the skin for this. In and out through your mouth, please. Again. We're going to do the same thing here. Go ahead and shield for me. We'll start at the apex. Good. In and out. Good. Now, as we auscultate, we'll hear normal sounds. The vesicular sounds should be heard over the parenchyma, tubular sounds over the trachea and bronchi. We may also hear abnormal sounds such as crackles caused by consolidation of pneumonia or wheezing caused by the obstruction of chronic bronchitis. And that will complete our exam.